Good evening, everyone. I think now it is 7 and this is the time we expect most members to log in. But I say log in because our webcast is starting at this time. I wish that we start. So my name is Dr. Joseph Abuya. I'm speaking you on behalf of KMA ELDORET Division, and I'm welcoming you to this webcast of today. So today, PFIZER Pharmaceuticals, in conjunction with KMA ELDORET Division, as the host, welcomes you to today's webcast. The webcast today is on a topic on proper management of lower respiratory tract infection. And our presenter this evening, we are privileged to have Professor Enoch Omonge. Professor Enoch Omonge is an infectious disease specialist in KNH. He's also a clinical pharmacologist at the Department of Clinical Medicine and Therapeutics in the University of Nairobi. He is an honorary specialist physician and a senior housekeeper in Kenyatta National Hospital. He is involved in reviewing and adoption of clinical protocols in various institutions. So I take this opportunity to welcome Professor Enoch Omonge to take us through. And please, anyone of you who may have questions for Professor Omonge, as well as what Anne-Marie will be presenting, you can post in the chat so that you can all see and share the questions, because at the end of this presentation, there will be a question and answer session, which Professor Omonge and other panelists will also be able to answer those questions. So welcome, Professor Omonge.
Thank you very much for that very kind introduction. I will load my slides. I hope you can see my slides clearly.
Yes, we are seeing your slides very clearly, Professor Omonge.
Thank you very much.
Seem to unmute.
So I wish to thank PFIZER this evening for this opportunity to present on the therapy of lower respiratory tract infection. I'm going to focus slightly on antibiotic treatment of lower respiratory tract infection, and the views expressed in these slides are my own. And I'm quite grateful that it's time we would have an interaction in this very important topic, appreciating that respiratory tract infection are among the major causes of disease. So Sir William Osler, who lived between 1849 to 1919, said, "The good physician treats the disease, but the great physician treats the patient who has the disease." And oftentimes we can treat patients as a disease condition, but a patient is not pneumonia. A patient is a person. And really, we need to interact with them, as we're going to see in my subsequent presentation. So for us to effectively treat the patients with infection very well, we must appreciate that we're dealing with a bacteria, a microbe, which has caused infection in the host, and we can mitigate this by giving a drug that has an impact on the microbe without harming the host. And now the strategies of good treatment begin with prevention. So source control to prevent the host from getting infected by the microbe. And we've seen with COVID, hand washing and using masks has been very effective. But we know the challenge of bacteria now is coupled with drug resistance. And so effectively, we have to be very clear that the drugs that we're giving are effective in managing the microbe. So how do we make antibiotic therapy appropriate? Now, this begins with having a clear idea of what is the bacterial etiology of the disease, who is the patient who we are giving the medicine? What is his kidney function, his liver function? Does the drug we are giving access the sanctuary of infection? And so these drug factors must be very clear. And this can be clearly achieved by having a good clinical history, a physical examination, and good laboratory imaging, and being cognizant of the local susceptibility pattern that will help us select the appropriate antibiotics. Now, some of the drivers of the inappropriate antibiotic therapy and therefore posing challenges to effective choice of treatment is there is very little surveillance data in Africa. And we know that many of the bugs are now become multi-drug resistant, and particularly when you're dealing with hospital-acquired infection and ventilator-acquired pneumonias. So when we give empiric therapy, we must make an informed choice by having surveillance data that will tell us what are the susceptibility patterns to antibiotics of the organism. What is like the bacteria? What is the susceptibility pattern? And therefore, then we can choose an appropriate antibiotic. Do appreciate that inappropriate antibiotic drives the evolution of multi-drug resistance. Now, this publication in the East African Journal that came early is one of the few studies that looked at strep pneumonia between 1999 and 98 and 99. They looked at over 500 patients who are seen, adult patients. And when you looked at the susceptibility to penicillin, 56.7 was susceptible to penicillin. And I do remember as a medical student, patients who were admitted with strep pneumonia were treated effectively with basic crystalline penicillin. Even as little as half a megaunit was effective in treatment of this bacteria. This indicated that obviously we were dealing with bugs that had no resistance mechanism and were very susceptible to basic penicillin. But you can see with the evolution of time, by the year 2007, the susceptibility had dropped to 33%, and subsequently around 2011, 2014, it was 19%. We now know that crystalline penicillin is not a very effective agent in treatment of many of these organisms, because with time we've had evolution of resistance. And one of the key drivers of resistance is inappropriate antibiotic use. Now, this graphical presentation looks at the total defined daily dose of antibiotics versus penicillin resistant strep pneumonia. And it looks at countries where there are stringent antibiotics guidelines. And if you look at the Nordic countries like Sweden and Norway, countries like Denmark, Germany, and Netherlands, where the consumption of antibiotic is low and the total antibiotic daily dose of antibiotic consumption is less than 20, the level of penicillin resistance is very low. And obviously in this institution, in a country like Denmark, crystalline penicillin at the time of this data would be effective in treatment of many of the community-acquired pneumonias caused by strep pneumonia. But if you look at countries where liberal use of antibiotics, like in France and Spain, where the daily defined dose of defined daily dose of antibiotic is high, approaching 40, the resistance for strep pneumonia to penicillin is very high, approaching 50%. And I think if we want to project this to the Kenyan data, you see by the year 2014, we had reached 19% of only susceptible, which means more than 80% was resistant. So that Kenya, where antibiotics are easily available, manifests very high levels of penicillin resistance. And this will tell us that the bacteria has evolved to be able to adapt mechanisms that will cause resistance. So the question we must ask when we prescribe antibiotics is, I'm giving my patient an antibiotic, is there a bacterial infection? So if there's a bacterial infection from my interaction with the patient, which is the likely causative organism? And if I have an empiric idea of what the likely causative organism, what are the local susceptibility pattern of that bug? And so we need data. And then we need to be able to risk stratify our patient for potential drug resistance. So that a patient who has been exposed to multiple antibiotic therapy, a patient who has been in hospital or in a nursing care facility for a long time, has a higher likelihood of having a resistant bug than a patient who has come from home and has not been exposed to antibiotic, has no comorbidity, and is young. So we have to select the right antibiotic based on this data we gather, and we have to give the optimal dose. Obviously, appreciating that if we use antibiotics for very long, we have significant collateral damage. If we use lower doses or antibiotics for a very short time, we drive resistance. And therefore, we have to deal with multi-drug bacteria. So how then do we approach this? We must ask ourselves every time we're seeing a patient with infection, could the bug be a multi-resistant bug? And this is only obtained if we methodically get information from the patient. And I've used the study subject to just illustrate how methodic we must be when we are taking history. And first we must ask ourselves, what's the history? Has the patient been on antibiotics? And the person who has previous antibiotic exposure in the last 90 days is likely to have evolved resistant mechanisms. The second question is to look at the patient's geography. Is the patient a referral? Is he a resident of a nursing home? Is he in a critical care unit? And obviously that will also be an important indicator of likelihood of resistance. Then we have to think of the biology. Is the sanctuary of the infection associated with potential multi-drug resistant bacteria? Does the patient have devices? Is there potential for biofilm formation? So a patient in ICU who has an NG tube, has an endotracheal tube, has a central line, has a Foley's catheter, is more likely to have bugs hidden in biofilms, protected, is more likely to be exposed to bugs that potentially mediate some resistant mechanisms. And we have to look at the physics. Is a drug molecule we are using large, small, polar, or zeta ionic? If you're treating a gram-negative bug, you need a drug that is small enough to pass through the bacterial porins to be able to reach the penicillin binding protein. You need a drug that is zeta ionic. If a drug like a carbapenem, which has both a positive and negative charge, and therefore likely to be neutral as non-polar, it will be effective in allowing that drug to traverse tissue and therefore to be more effective and more protective from resistance. So the physics of the drug is important. How about its chemistry? What is the stability of the molecule to metabolizing enzymes? We know there are enzyme systems, there are efflux pump mechanisms that can flux the drug out from its target and therefore drive resistance. So the chemistry of the drug is important. How about the mathematics? Are the doses adequate? And if you're looking at the PK/PD parameters, have you given enough of the medicine? If you understand the bug in one area, one dose X may be effective in treatment of infection, but in the second area, based on the MIC, you may need to double your dose to 2X to be effective. So that mathematics is important, and you'll only be able to appreciate it if you explore literature. What does the surveillance data say? What does published data say? What does our local antibiogram say? For example, if you have ongoing surveillance data in ELDORET, you need to appreciate how the bacteria in ELDORET behave in terms of susceptibility to drugs and in terms of minimum inhibitory concentration that will inform the doses of drugs that you may need to use in that locality. Now, as you want to give drugs for the bug, you have to remember that bacteria can have a cell wall, or they may be atypical bacteria with poor cell wall. And so if you're looking at bacteria with no cell wall, such as Mycoplasma chlamydia, Legionella disease. You know that the antibiotic you choose should not target the cell wall, and therefore, in such situations, you may need to use a macrolide or a fluoroquinolone because they do not work on the cell wall, they work on nuclear structures and on protein synthesis, on the ribosomal subunit. But if you are treating a gram-positive or a gram-negative bug, you have to appreciate that they have a cell wall. And the cell wall structure is made of peptidoglycan. And to make this cell wall, you need an enzyme. And that enzyme is known as the penicillin binding protein. The penicillin binding protein is the one that binds the peptides with the glycans to weave a cell structure. And therefore, if you're using a beta-lactam antibiotic, such as penicillins, cephalosporins, carbapenems, you're using them on the premise that these drugs have beta-lactam structure that will prevent the penicillin binding protein from forming a mature cell wall, and therefore you'll damage the bacteria. But then we need to appreciate, even as we look at those molecules, that they are varied. The first generation cephalosporin is different from the third generation cephalosporin. The narrow spectrum penicillin, like penicillin B, is different from a broad spectrum penicillin like amoxicillin, and still different from an extended spectrum penicillin like veracillin. And so when you are treating gram-negative bugs, your approach is slightly different from when you're treating gram-positive bugs, because you know gram-negative bugs, apart from the peptidoglycan, they have a liposaccharide outer membrane that have very small pores, and so you need smaller oswiter ionic molecules that can traverse this outer membrane to reach the penicillin binding protein and to stop bacterial cell wall formation. But remember, you are in a war between the bacteria and the drug. So the bacteria has also evolved mechanisms to protect itself from drugs. So the pore structures may change, and if the pore structure changes, this general poring changing, the drug may not be able to go through to be able to reach the penicillin binding protein to stop the cell wall formation. The drug may be small enough to pass through the poring structure, but when it reaches this periplasmic space, there are enzymes called beta-lactamases that will break the drug, because the gram-positive and gram-negative targeting the cell wall are treated using beta-lactam antibiotics. And if you break the beta-lactam ring, the beta-lactam antibiotic will not be available to bind on the penicillin binding protein. And therefore there will be resistance because of beta-lactamases. We also appreciate that the penicillin binding protein itself may change, and the drug may not be able to fit because the ligand will not fit on its receptor very well. And so that can be a mechanism, the changing of the penicillin binding protein. And lastly, we may have an efflux pump mechanism that is able to flux out the drug as you give it in. Now, appreciating these resistant mechanisms, knowing that you're dealing with an atypical bacteria or you're dealing with a gram-positive, gram-negative, helps you to be able to select the drug rationally, so that effectively, if you know the bug, you know the drug, you know the resistant mechanisms that potentially can occur, then you'll select, make an informed choice of choosing the right drug. Now, there have been patient risk stratification bundles that helps us predict who is the patient who is likely to have resistance. And if you look at this stratification bundle, which was proposed by Israeli infectious disease known as Yehuda Carmeli, he stratifies patients into 3 strata. The first group is a healthy young person who has no comorbid condition, has not used antibiotics in the last 90 days, and has no contact with healthcare facility and has had no instrumentation of any other procedure. Now, if you see this patient come to you with a lower respiratory tract infection, has a history of a few days of cough, chest pain, production of sputum, etc., you will know that you're likely to be dealing with a community-acquired pneumonia in a patient who has no healthcare contact, is otherwise very well, and so the bug is likely not to express resistant mechanisms. And therefore, you want to use a susceptible narrow-spectrum antibiotic. So there is no need for broad-spectrum antibiotics. That we have a lot of bacteria that exercises antibacterial properties. And if you get rid of normal bacteria, you allow other infections to take place, because they also express some antibacterial properties that prevent drugs from pathogens from accessing sanctuaries where they are not supposed to be. So obviously, you do not want to use a broad-spectrum antibiotic when you think you're dealing with a community-acquired infection that needs a narrow-spectrum drug. Additionally, we want to deal with cost-effective treatment of our patients. However, when you're dealing with hospital-acquired infections and ventilator-acquired infection, you're dealing with a type 2 kind of infection, where a patient you see may have had multiple contacts with healthcare providers or has previous antibiotic use in the last 90 days. They may have instrumentation if you are there on ambulatory care, and usually they have comorbid condition and they may be older. So such patients may have evolved bacterial resistance mechanism. And we're going to discuss two kinds of resistant mechanism out of the 4 mechanisms I've mentioned when I looked at the gram-negative cell wall. You may have production, which is the most common, of beta-lactamases. This beta-lactamases can be narrow spectrum, and a narrow spectrum beta-lactamase is so narrow that it will only break penicillins and amoxicillin. But then you can have broader spectrum beta-lactamases. We call them extended spectrum beta-lactamases because they have extended their spectrum of destroying drugs to even destroying the KFM ring, the cephalosporin ring. And therefore, this may be expressed by organisms such as Klebsiella and E. coli. And these are bugs that you commonly see in hospital-acquired infection. And so as you target them, you want to use drugs that are effective against extended spectrum beta-lactamases. And so in as much as in this first spectrum, you may use amoxicillin, in this second spectrum, you may need a more extended spectrum penicillin like piperacillin. In as far as you may use plain penicillin here, you may need to augment the drug you use in this spectrum by adding a beta-lactamase inhibitors such as clavulinic acid or tazobactam. Then there are those patients who have prolonged healthcare exposure, they have had procedures, they have repeated multiple antibiotics, they may be immunocompromised with many conditions, and these patients, not only will they have extended spectrum beta-lactamase, they may be infected with Pseudomonas and Acinetobacter. These two are known as non-lactose fermenters, and they express a lot of multi-drug resistance profiles. And so these other agents may require, to be treated with anti-pseudomonal antibiotics. And in this type of infection, you oftentimes have to use carbapenems like imipenem, meropenem, and doripenem. And therefore, as you consider the other anti-pseudomonal antibiotics, that becomes very key in this patient. Now I want to give you a clarity of what I've discussed in the previous slide. So appreciate that a naive bacteria that will respond to the beta-lactam ring, and these are the beta-lactam ring structure. So if you're dealing with a bug with a cell wall, such as staph, strep, Klebsiella, E. coli, Pseudomonas, you need an antibiotic that may act on the cell wall. If you're dealing with a bug that has no cell wall, such as Mycoplasma, Chlamydia, Legionella, you may need to use a macrolide. which will work on protein synthesis, or a fluoroquinolone, which will work on DNA gyrase. And so this selection of drugs is based on our understanding of this drug. We have basic penicillin, which has a beta-lactam ring that is not very stable and can be destroyed by a limited spectrum beta-lactamase. We have a more stable KFM ring, which is a beta-lactam ring found in the cephalosporin. And because it's more stable, it can withstand limited spectrum beta-lactamase. And so to destroy this, you need a beta-lactamase that has a more extended spectrum beta-lactamase. Now, if you really need a very stable ring, you need the penem ring. The penem ring is the beta-lactam ring that is found in carbapenems. Remember, carbapenems are very small molecules. They are zwitterionic, that is, they have an overall zero charge. And so they'll get very easily into the porine structure. And this ring is so stable that you can't break it. Therefore, it will have a very broad spectrum of treatment of infection. So really, if you look at the cascade of choosing antibiotics, you appreciate that naive bacteria that have no resistant mechanisms will be easily treated with narrow spectrum and broad spectrum penicillin, like penicillin and amoxicillin. But as soon as there's evolution of resistant mechanisms, and you've seen what happened in Kenya up to the year 2014, that only about 19% of strep pneumo was susceptible to penicillins and amoxicillin, that with this evolution, you lose your efficacy of this beta-lactam ring in the penicillin to bind on the binding protein, because they are producing limited spectrum beta-lactamases that will destroy penicillin ring. So our choice of antibiotic, when you cannot effectively treat that bug with the penicillin, is either to use a cephalosporin, because the KFM ring is more stable and will withstand the limited spectrum beta-lactamase, or look for a suicide molecule that will keep the beta-lactamase busy. And you can use clavulanic acid. Clavulanic acid has a beta-lactam. And when you use it in combination with narrow spectrum penicillin, like penicillin and amoxicillin, the beta-lactamase will go for it because it has a higher affinity for clavulanic acid than amoxicillin. And therefore, you'll then use amoxicillin clavulanic acid combination, or choose a more stable KFM structure of cephalosporin when you know you have limited spectrum beta-lactamases. Remember that when you use clavulanic acid, you gain benefit in terms of spectrum of activity, but you also have a little more in terms of adverse GI drug effect. Now, how about if you now have extended spectrum beta-lactamase? It means that now even your KFM ring will not withstand the beta-lactamase. And therefore, you need a more stable penicillin and a more stable molecule than clavulanic acid. And therefore, you use an extended spectrum beta-lactamase, such as piperacillin, and a more stable beta-lactamase inhibitor, such as tazobactam. And so when you're looking at ESBLs, you're looking at bacteria, usually Klebsiella, E. coli, are very common hospital-acquired bugs that have loaded up the mechanisms to withstand cephalosporins, particularly third and sometimes fourth generation cephalosporins. So then you want a more stable molecule, piperacillin, an extended spectrum penicillin with tazobactam, a more stable beta-lactam inhibitor is a feasible drug to use. Now you may use ertapenem, which is a class 1 carbapenem, because it's also stable to extended spectrum beta-lactams. But appreciate sometimes you really want to spare your carbapenems, and therefore rationally you will choose to use piperacillin tazobactam for many of the extended spectrum beta-lactams. Now, I also want us to appreciate that then you need to know from your lab, because you have surveillance data, which mechanism the bacteria is using. Is it producing beta-lactamase? And if it's producing beta-lactamase, which beta-lactamase is it producing? And therefore, with that information, you can decide whether you want to use azobactam with the piperacillin or ertapenem. Now, but bacteria can be very difficult and they may have multi-drug resistant mechanisms. And so the drugs with multi-drug resistant mechanisms, the bugs with multi-drug resistant mechanisms will need extremely stable molecules. And class 2 carbapenems such as meropenem, imipenem, cilastatin, doripenem are the ones of choice when you're dealing with MDR bugs. And MDR bugs tend to be strata 3, can be Pseudomonas, can be some of the Klebsiella pneumonia, and in those patients, you may need to use carbapenems. Now, obviously, no drug escapes resistant mechanism. And there are bacteria that produce carbapeneses that can even break this penem ring. And in those, therefore, you'll end up requiring a drug that has big stability. And one of the molecules that is currently important in management of the extremely resistant carbapenems producing is ceftazidime with avibactam. Avibactam is a non-beta-lactam beta-lactamase inhibitor. It's slightly different from clavulanic acid and tazobactam. And its major difference is that it can be recycled. So it's available. So when you give avibactam with ceftazidime, the beta-lactamase, which is extremely extended, even breaking carbapeneses, will be very busy breaking down the avibactam and allows the ceftazidime to work. And this will harness very great stability to this drug. So ceftazidime avibactam has improved the armamentarium of drug selections that is available for MDR bugs. We also know that in ICUs and in patients who are highly resistant and carbapenems production, colistin with high dose meropenem can be used because polymyxins are effective. Tetracycline and aminoglycosides may also be considered. There are newer molecules, siderophores and etc. that are on the horizon for treatment of MDR bugs. So how do we then optimize our patient's experience? And I think a good physician must learn the virtue of listening. Remember, it's important to get a good history. The word history is made from the prefix his and the suffix story. Listen, the story is the patient's. And so you really have to listen to your patient because your patient will tell you at the end of the day, I have strep pneumo, I have mycoplasma pneumonia, I think I have Staph aureus. And if you are a good listener, you'll always get that data, as I'm going to illustrate to you shortly. Now, the second thing you must do is touch your patient. The greatest attribute of any successful relationship is touch. Doesn't matter what kind of relationship. And so for us, we must examine our patients. We must touch them physically, but we also must touch them by being keen listeners and talking to them because talk is the great medicine. So I always believe in the triad, listen, touch, and talk. I must tell my patient what I'm giving him, why I'm giving it to him, what's going to do for him, and my anticipation in terms of his response to treatment. So I'm going to give us a case study to just illustrate how we go about choosing antibiotics. And I will start with GM, who is a 32-year-old male and is seen in an outpatient department with a 7-day history of dull left chest pain. He is producing scanty mucoid sputum when he coughs. GM has no previous illness or hospital visit. He reports fever, general malaise, headache, and joint pain. He has no history of rhinorrhea or sore throat. Now, this is where the distinction comes in when you see a healthcare provider who listens. And if you listen to this patient, these are some of the facts you're going to speak. That GM is 32, is a young male. He has not visited the hospital. He has no comorbidities. And that gives you the understanding that this is a strata 1 patient and is unlikely to have resistant bugs. He has evolving signs and symptoms over 7 days. So if he has a chest infection, it's going to be a subacute type, and unlike acute strep pneumonia, which presents with a 1 day or so history of cough, chest pain, and producing rusty sputum. Then you see there is no intense inflammation. His cough is mucoid. And so if you're listening to the patient is telling you, I have mucoid expectoration of sputum. I'm producing only mucus in my airway because my problem is an inflammatory process in my airway. It has not gone to affect my lung tissues significantly because the bacteria does not have a cell wall. If it had a cell wall, it will cause an intense inflammatory process in my lung, and my lung will become solid. So it will construct solid consolidation. And if it's solid and you cough, you'll break it and you'll produce blood. And therefore you may either have hemoptysis or rusty sputum. And because the bugs such as strep pneumo produce virulence factors and cause intense inflammation, the history is 1 or 2 days. The pain is focal, it's localized, it's not diffuse. They can point at it, I'm getting pain here. The pain is not dull, it's pleuritic. The patient has told you they have dull pain. Now the patient has no catarrhal symptoms. Remember we said he has no sore, no conjunctivitis. And indeed, if a patient who has a lower respiratory tract infection has catarrhal symptoms, it will suggest a viral infection. It could be a viral pneumonitis. We know there are unique things we are even seeing now in COVID patients who come with significant shortness of breath, loss of smell, and loss of taste, that for the listening ear will tell you that this is COVID pneumonia. They are breathless because they're not oxygenating. They're not oxygenating because the lung is inflamed. Some people have COVID but not have significant inflammation. So obviously, as you listen to the patient, you can tell the severity of the disease and the likely bug that is causing the disease. The fact that the patient has no recent antibiotic therapy tells you that this is a bug that has not been exposed to antibiotics, and therefore resistance is unlikely. And the fact that the patient has headache and arthralgia tells you the patient has extrapulmonary symptoms. And when you get extrapulmonary symptoms, you are likely dealing with an atypical bug or a viral infection. And if you have a flu-like illness, you'll get a headache, you may get joint weakness, you get muscle ache. If you have an atypical bug like Mycoplasma, Chlamydia, Legionella, you may get headaches and arthralgia. And so the patient has told you, I'm young, I have no other disease, I've been sick with a subacute presentation. My inflammation is more of attractive bronchitis rather than a deep tissue involvement. I have not viral infection. I have not used antibiotics. And because of my extrapulmonary symptom, I'm likely to have a bug that has no bacterial cell. And so when you go on to do the second thing, which is to touch the patient, you go feasibly looking for clinical signs. I can bet, even as I speak to you, that oftentimes we may examine patients very casually. And the first thing the doctor will reach out for is to take the stethoscope and put on the chest to listen for cracks. The stethoscope is one of the tools that you don't need in clinical practice, and you need it very unusually. Oftentimes, shortness of breath and good clinical signs will tell you who likely has bacteria. So do we take temperature? It's not unusual to find notes with the word temperature written and no record of temperature. And it's also not unusual to find a note that has a temperature of 37.8, and the healthcare provider has not appreciated the difference between a temperature of 37.8 and that of 39 or 40 degrees centigrade. So vital signs must be taken because vital signs are vital. Vitals are things that you need. For example, we need vital amines, vitamins. They're small things, but you need them for normal health. So vital signs are important for making decisions. So when you see a temperature that is 37.8, it tells you that your inflammatory substance production is not high. Strep pneumo has in its cell wall a lot of inflammatory mediators. So a person with strep pneumonia is likely to have a temperature of like 940. But a person with a bag that has is atypical will cause a low-grade fever, as we're seeing in GM. The blood pressure is normal, a reading again often not recorded, and many times copied from what has been taken at triage. So what is the essence of pulse? Pulse will tell us if you are responding to fever. And a normal person, if you have a febrile illness, will have an increase of pulse by 15 to 20. So when you have a normal pulse hit of an infection, it is an abnormal response. You see it in enteric fever. Patients with typhoid fever will have high fever, but no pulse response. You see it in yellow fever, and you see it in atypical bugs. If you have strep pneumonia, your pulse rate is going to be more than 100 because you're producing virulence factors. So this patient, when you touch him, he's telling you that this is unlikely to be a cell wall aggressive bug. And please look for Mycoplasma chlamydia because you listened to my history. And as you touch me, you are confirming my history. Is this a patient cyanotic or a cyanotic? If a patient is cyanotic, am I thinking of PCP? If the patient has lymphadenopathy, is it likely mycoplasma? And if there's no lymphadenopathy, do I want to think of chlamydia and mycoplasma? Is there conjunctivitis? Is it a viral pneumonitis? And therefore then, as you classically take your stethoscope, you already have decided what likely bug you are dealing with. The auscultation may give you sparse crepitations, which means that they are more infiltrates rather than an homogeneous density with consolidation like strep pneumo, which will give you bronchial breath sounds and crepitations. So obviously, each of these is important. Touch is important. Know if a patient has low-grade fever, know if they have sepsis and they are hypotensive, see the pulse, and look for features that suggest viral infection. So the moment of antibiotic decision making is built on you being able to say, does my patient have an infection that requires antibiotic treatment? Have I ordered the appropriate culture before initiating antibiotics? What is the empiric therapy that I should initiate? And how long am I going to give these antibiotics? Do I need to change this patient to oral at one time? Do I really need to admit him? Or can he go home on oral medication? And how long should I continue therapy? Now, in terms of investigations, oftentimes as an outpatient, if you listened properly to your patient and characterize him the way we have looked at GM, you may require no investigations. You can, with certain detailed interpretation, say that this is likely a bacteria with a cellular structure, and because there is productive of rusty sputum, the patient has high-grade fever, the patient has a tachycardia, and has classical crepitation with bronchial breath sound. This is strep pneumo. So I'm going to treat as strep pneumo. And because the patient is in class 1, I'm going to give another spectrum antibiotic. You can say my patient is an inpatient, but is not severe. I can do a sputum smear, and I can decide whether it's gram positive or gram negative. And if your patient has Klebsiella, he will have produced sputum that is usually current appearance, and the patient will have high-grade fever because it's a gram-negative organism, and you can stay in the gram-negative organism and using other supportive data be able to distinctly say, for Klebsiella pneumonia, I need to take a different antibiotic. If your patient is an inpatient, but not in ICU, is moderate to severe, then you now need to take blood cultures. In studies, between 7 to 20% of your patients may have positive blood culture. The numbers may be as low as 1 to 2% in some settings. But obviously, bacteremia is a prognostic indicator of lower respiratory tract infection. In those patients, again, you can use urinary antigen to be able to pick quickly using those panels to pick Legionella and pneumococcal urine antigen. And so for these severely ill patients, you have adequate information to make treatment. Now for your patients in ICU, I think you need to broaden your interventions in terms of investigations. And additionally, you may require to look for TB, fungal infection. You may even need to do biopsy of tissue to be able to pick the causative organisms. So for our patient GM, we did blood sugar, we looked at his renal functions, his blood culture and sputum, and the chest X-ray was done. And this was the X-ray for GM. He had this homogeneous density and some infiltrates, obviously no significant lymphadenopathy, and strep pneumo will not give you patches of non-homogeneous density as seen in this left lung. So would you admit this patient or treat him as an outpatient? And from what we have gone through, we've appreciated that this is an atypical bug, and this is a patient who is ambulatory, does not have sepsis, and you can give him a macrolide antibiotic or an oral fluoroquinolone and send him home. But the game becomes different when you're dealing with more severe infections. So early pneumonia, early onset pneumonia usually would be caused by community-acquired pathogens and usually are susceptible. So if it's strep pneumo, Haemophilus, or Staph aureus, you may not need to use antibiotics that cover potential drug resistance. So when you're looking at microbiology of a community-acquired pneumonia, the truth is oftentimes we do not know the organism. And that's the essence of what I've gone through in terms of capturing your history and your physical examination and getting ideas from things such as mucoid sputum, purulent sputum, current sputum, being useful for atypical bugs, rusty sputum for strep pneumo, current sputum for Klebsiella pneumonia, and purulent sputum for Staph aureus, etc., being able to guide empiric therapy. However, strep pneumo is among the most common bug you'll pick, where you have you isolate bugs, followed by some of the atypical intracellular pathogens. But I want us to appreciate these common groups that you'll see in hospital-acquired infections that have gram-negatives and potential drug resistance, such as Staph aureus, because we are slowly getting severe infections because bacteria are essentially becoming more and more drug resistant. So for late onset pneumonia, you think of hospital-acquired pathogens. And commonly these are gram-negative bacteria, Enterobacteriaceae, that have extended spectrum beta-lactamase production, such as Klebsiella pneumonia, Escherichia coli. You will see the non-lactose fermenters, such as Pseudomonas and Acinetobacter baumannii. And obviously, you must consider the MRSA. And so if you look at the Sentry data, which looks at some of the organisms that have been found in hospital-acquired infections, you'll see that largely the more potential drug-resistant bugs are taking center stage. Pseudomonas, Klebsiella, Acinetobacter, and E. coli, and all these bugs, gram-negative, will cause a significant resistance. So that tells you you're not going to use a basic penicillin, and you are unlikely to benefit from using anticephalosporin in hospital-acquired infection. And if you have Staph aureus, you're worried about potential of methicillin-resistant Staph aureus. So what do we do in essence in practice using our biomarkers? A white cell count is important for us to tell if a patient has infection. And oftentimes we give antibiotics because patient has a fever. Fever is an indication of potential antibiotics, but you don't treat fever with antibiotics. You treat fever with aspirin and paracetamol. So if your prescription is based on only fever, the use of antibiotics is devoid of evidence. So you need other markers. What is your response to blood counts? Do you have a white cell which is more than 11 times 10 to the 9? You have a raised C-reactive protein. And again, data from C-reactive protein must be used with other data, because oftentimes you can make a joke that there's an A that is missing between the R and the P if you are using CRP only as your agent of making a decision. So what are the other important biomarkers? Procalcitonin has become a very useful biomarker because it tells you earlier when there's an infection, tells you of the severity, and use it for prognostication. And we know when the procalcitonin decays by 80%, you know that you have treated your patient adequately. There are newer biomarkers such as MALDI-TOF. MALDI-TOF means matrix-assisted laser desorption ionization time of flight, in which you can make an immediate diagnosis of what the bacteria when you're looking at laser desorption ionization, and you can do spectrometry to try and see what is the potential bug. So these biomarkers must be used also very well. Do not do procalcitonin for outpatients. It's a waste of their money. If you can listen to your history, you can do a physical exam. If you can see there is obvious infection, you really do not need a procalcitonin to decide that there's an infection. But if you have a patient with a hospital-acquired infection, a patient in ICU, these biomarkers become very useful. Now, it's not unusual for a lot of chest X-rays to be used to define if a patient is going to be treated for TB. And any of this would have been treated for TB. But in essence, this panel represents mycoplasma. That was the X-ray of GM that we saw. Staph bronchopneumonia, which causes microabscesses, pneumatocysts, and can cause atelectasis, and that can be confused with TB and Haemophilus pneumonia. So you must examine sputum and see if there is AFBs, because that will direct you when there's TB. Now, imaging can be diagnostic. I want to take you through these two series of X-ray. This is a frontal radiograph of a patient who has an submaxillary consolidation, and a few weeks later, you'll see there is some cavity and atelectasis, and this is staph pneumonia. Staph pneumonia tends to break down, forming pneumatocysts. It will form microabscesses. This is a very sick patient, often subaxillary. So this is a very sick patient. But our knowledge of potential typical radiographic pictures with the accompanying history and physical exam will make us pinpoint an organism even without a culture. This other patient has homogeneous density, but when you look at the lateral, you'll see a bulging fissure. This is classical of Klebsiella pneumonia. So every information that you pick should help to guide us to make a diagnosis. And as our patient transits from a community-acquired to an intensive care patient, we must remain cognizant that now we are seeing more and more mixed infection, more and more gram-negative infections that potentially will express extended spectrum, beta-lactamases, and therefore we also want to use drugs that have an extended spectrum activity, such as upgrading from amoxicillin to piperacillin. We want to use a stronger beta-lactam-lactamase inhibitor, such as grading up from clavulanic acid to tazobactam. And we may also appreciate that in an extensively resistant bug, you may be thinking of going on to drugs such as avibactam to potentiate the effect of our beta-lactam drugs. Appreciate ventilator-associated pneumonia can be seen in patients who have been intubated for more than 48 hours. So the essence of us risk stratifying patient, going through a series of building of historical data, and looking at the severity of the disease, appreciating whether the patient is an inpatient, outpatient, or ICU will help us profile the antibiotic that we select. Just a mention of what you see in staph pneumonia. As I said, it breaks tissue, it may be cavitary, it may cause a pleural effusion, you may have gross hemoptysis. It's common during the influenza outbreak, you'll have neutropenia. And that's why I say a white cell response is very useful in associating the treatment, the bag, and clearly building up in our history and physical exam, maybe a young patient, maybe severe pneumonia. So empirically, treatment for staph aureus and in centers where they see MRSA, considering the potential of MRSA, will be guided by, is there a high local prevalence of methicillin-resistant staph aureus? Is the patient known to have had MRSA colonization or infection? Is he an IV drug user? If the pneumonia is breaking down the lung like we've seen in staph aureus, is there necrosis, necrotizing pneumonia? Is the patient ill appearing, has been to a nursing home, in hemodialysis center, prolonged hospitalization? Then we will choose the drugs that are useful in staph aureus, which potentially will have MRSA. And those drugs are vancomycin, linezolid, and daptomycin. Now remember, you may choose the right drug because the lab has told you that that sample you sent, when we put it on a disc and we put the drug on the disc, it was susceptible. But you must ask yourself, where is the infection? Daptomycin will show susceptibility for staph aureus in the lab, but if the staph aureus is in the lung, daptomycin is broken down by surfactant. So the fact that you're told a drug works because the lab guy has taken the bag and put it next to the drug and it works, does not mean that is the drug you're going to choose. If you have meningitis and the drug works, but it does not cross the blood-brain barrier, you can't use it. If you have a pyelonephritis and the drug works in the lab, but it is lost via the hepatobiliary route in the stool, you can't use it because it will not access the sanctuary where the infection is. So these guidelines for community-acquired pneumonia, and the reason I put this slide is to tell you that every facility must have its local data. Americans have their way of handling community-acquired pneumonia, distinctly different from the British and the Europeans, because their surveillance data will dictate the susceptibility of antibiotics. Now, can you use fluoroquinolones? Yes, they are very effective. Moxifloxacin, levofloxacin are very effective respiratory antibiotics. But do remember, you must compare the risk-benefit. So if your patient has a risk of getting an aortic aneurysm, an elderly patient, you must appreciate that fluoroquinolones can have effect on collagen and can cause certain damages to cartilage and even the vasculature, and they have a higher propensity to cause aortic aneurysms than the beta-lactam antibiotics, as depicted by this graphical presentation. So you must look at risk-benefit as you choose the antibiotics. Don't just say, in my practice, I use levofloxacin, you use it across board. In my practice, I use ceftriaxone, you use it across board. In my experience, it's not about our experience, our practice. It's about the bag and the drug and what data tells you, the interaction of drug, bag, and safety of the patient who is getting that treatment. So, I just want to look at some of the important consideration when you're looking at hospital-acquired infection. And as I've told you, the gram negatives are important: Pseudomonas, Klebsiella, Acinetobacter. So obviously, you are not going to use some of the basic antibiotics because here, you have extended spectrum beta-lactamases being potentially reproduced. And we know that some of these bugs produce ESBLs in our setting between 30, 40%, and sometimes even more. So empirically, you want to use drugs that will capture these bugs. And so you have a choice of either using an anti-pseudomonal cephalosporin, which is a 4th generation or a 3rd generation cephalosporin. But again, do remember that ESBL and MDRs may sometimes affect this choice. And therefore, you either use anti-pseudomonal carbapenems such as imipenem and meropenem, or beta-lactamase inhibitor such as piperacillin tazobactam. And indeed, when you look at the molecules and you appreciate the beta-lactamase inhibition, you appreciate why we are rationalizing these choices for treatment of either Pseudomonas or Klebsiella or E. coli or Acinetobacter. Then, should you use a fluoroquinolone? You must ask yourself if you can use a respiratory fluoroquinolone. Remember, when you see ESBL, these organisms, even when you have a susceptible fluoroquinolone, tend to evolve DNA gyrase very quickly. And when you make that choice, you must follow your patient to appreciate that have you really used the right choice. Aminoglycoside antibiotics we spare a lot, and in patients with good kidney function, empirically, you can use them with combination with beta-lactamase inhibitor, and some of the cephalosporins. Remember, for MRSA, we said you can use linezolid, vancomycin, and remember, or teicoplanin, but remember, we said you cannot use daptomycin because it's broken down by surfactant. In ventilator-associated pneumonia in ICU, the same kind of algorithm will work. And when you're using gram-negative cover for anti-pseudomonal activity, again, 4th generation cephalosporins and some 3rd generation cephalosporins, and carbapenems may be used where you have extensively drug-resistant MDR bugs. Monobactams are a choice. Aminoglycosides, and in patients who are producing carbapeneses, colistin would be a choice of antibiotic. So, looking at this in perspective, in summary, having appreciated the flow, always ask yourself, am I dealing with a wild type gram-negative from the community in a young person who has no resistance? And I'll use a basic penicillin. Is a patient likely to be producing a beta-lactamase limited spectrum? And I'll either use a cephalosporin or augment the penicillin. That is why we call it augmenting, because you are augmenting the penicillin with clavulanic acid. Now, if it is a likely extensive ESBL, then the beta-lactamase inhibitor should be extended spectrum, piperacillin, augmented with tazobactam, which will be more effective than amoxicillin with clavulanic acid. Then if the patient is producing extended spectrum, then consider carbapenems. But when you have carbapenems production, you need novel agents like ceftazidime avibactam or polymyxins. And that is illustrated in this diffusion, Hinton-Eggard diffusion illustration. This is a bug which is carbapenems resistant Klebsiella pneumonia. Now, when they tried to use etapenem, meropenem, and imipenem, you see the zone of inhibition is very little. Now, if on the other hand, they use ceftazidime with avibactam, then the zone of inhibition is larger. So ceftazidime avibactam then becomes more potent than carbapenems in a patient who is producing carbapeneses. And then the zone of inhibition becomes much higher because avibactam is a stable beta-lactamase, and the bug will be busy breaking avibactam and allows ceftazidime to work. But you can improve that by using either etapenem, meropenem, imipenem in combination with ceftazidime avibactam. And look, amazingly, how that zone of inhibition shows synergy. So in those extensively resistant organisms, one can appreciate why these novel agents have become part of the therapeutics. So a concept map consideration is you map out the resistance mechanism, and if it is high-level resistance, carbapenemase production, you know you're going to use colistin. But if the mechanism is non-carbapenemase, then you have low-level resistance, then the treatment of choice may be using slightly friendlier regimens. So I leave you with this algorithm where, based on our discussion of potential resistant mechanisms and looking at rationalizing selection, when you're looking at Enterobacteriaceae, where you can either use a carbapenem or a piperacillin tazobactam, which is a beta-lactamase inhibitor, appreciating the spectrum of the beta-lactamase, or other mechanisms in Pseudomonas where you must use carbapenems or tazobactam. And if your lab surveillance data will tell you that the mechanism of AMP-C will respond to beta-lactamase inhibitor or class 1 carbapenem, those will be the choice. And the last, carbapenemase resistance, will give you choice of whether you use azidine, mavibactam, colistin, tigecycline, or plus high-dose carbapenem. So this helps us have a clear interpretation of data and helps us appreciate why it is important for local surveillance to give us data on how bugs behave. And finally, do we use inhaled antibiotics? Sometimes appreciate the alveoli. When you give an antibiotic, you want it to use the endothelial lining fluid. If this is a wall of the trachea, and this is inside the alveoli, and this is the lining fluid where the bug is, when we give IV drugs, we give them on the premise that they will penetrate and get into the endothelial lining fluid and kill the bacteria. But remember, this area may have a zone of occlusion known as zone of occludence, and there's connective tissue that may not allow drugs to penetrate. And so in some extensively resistant bugs, where you cannot get your drug to this endothelial lining fluid, you will see the use of inhaled antibiotics in patients in ICU with multi-drug resistance. And that will be a discussion for another day. So my take-home message is use antibiotics for bacterial infection. Think of the likely causative organism. It's good to have local susceptibility pattern, and at KNH and many of the hospitals in Nairobi, we now have susceptibility patterns that we have used to generate treatment protocols. Risk stratifying your patient for potential resistance. Select the right antibiotics and give the right and optimal dose. Thank you very much. I hope it's been clearly delivered. Thank you.
Thank you, Professor Enoch Omonge, for such elaborative and educative that we have learned in these lower respiratory tract infections, and especially on proper management of these conditions. I know there will be a number of some questions here and there. When that session reaches, I hope I'll ask some of the members to raise their hands and we'll give them an opportunity to say something. I take this opportunity to welcome Anne Muraidi from PFIZER to take us through. And I also wish to acknowledge that one of our secretary, the Honorary Secretary, Dr. Edith Koba, is with us, and at some point you'll be able to take over from me and continue with this discussion. So welcome, Anne. And is going to take us through on their, even including range of products. And how are you? Could you please start sharing your slides? As Anne is preparing to share her slides, I welcome Dr. Edith Koba to say something, and probably she might be taking over from me. Dr. Edith, how are you?
Hello, Dr. Abuya, how are you?
I'm fine, Dr. Koba. Please, at some point, you'll be able to take over from me. Hopefully, if everything goes on well.
We can talk on the side about that, but I thank the presenter, Dr. Omonge, first. It's been, even for a psychiatrist like me, it's been an awesome reminder of what we should do when we're handling the respiratory tract infections. And he's always a good teacher. He's my undergraduate teacher, and as always, he doesn't disappoint. We greatly appreciate as KMA ELDORET Division for having him here with us.
Thank you, Dr. Koba. It's true that we have learned a lot from Professor Omonge Enoch, and I'm sure that we'll engage him in a few questions. Even some of us who are in the line of radiology were reminding about the Staph aureus, the kind of patterns they present, the Haemophilus and others. I'm seeing Anne is ready. Please, yes. Anne, you can take over.
Oh, okay. Sorry about that technical hitch. Good evening, everyone. My name is Anne Murithi, and I work for PFIZER. And I'd like to start by thanking Professor Omonge for that excellent and elaborate presentation. I believe now we have a better understanding on our choice of antibiotic therapy when it comes to lower respiratory tract infections. Looking at my slide, which I hope you can all see, there's an elephant, the largest mammal on land, that is trying to do a balancing act on a ball. So you can imagine how huge it is, and it's trying to get it right. And if not, you can only imagine the kind of disaster or quake that would happen. So basically, tazocine tazocine will help you in getting the balance right when it comes to efficacy and safety. So I'll start with a disclaimer that PFIZER does not suggest or recommend the use of PFIZER products in any manner other than as described in the prescribing information approved by the local regulatory authorities. So we'll start by understanding what is particulate matter. And this basically consists of useless substances that cannot really be quantified by chemical analysis due to their small size and varied composition. So anything that directly or indirectly comes in contact with parenteral solution is particulate contamination. So this will include glass, cotton fiber, dust, or latex. So basically, this particulate matter may clog your major organs like the lungs, liver, and the spleen. And you can imagine you're trying to treat an infection, probably even a life-threatening infection at this point, yet you're causing more damage by the deposition of this particulate matter in your major organs of the body. So tazocine enhanced formulation has an added advantage that it can be administered simultaneously via a Y site. So especially when you have to do combination therapy, like in nosocomial pneumonias, then you can give tazocine and an amicoglycoside via a Y site. So in this case, it also saves you that time when you're doing the IV administration. So another added advantage of tazocine per se is the fact that tazocine has the addition of sodium citrate, which basically will act as a buffer and control the pH in the body, hence solve the particulate matter formation, which we discussed earlier. So again, you don't want a low pH in the body because it will increase the rate at which particulate matter is formed. So again, the EDTA will act as a metal chelating agent, and these two additions will make tazocine enhanced formulation stand out from the other piperacillin tazobactam in the market. So if we look at in lower respiratory tract infections, there are certain risk factors that you look out for patients who have MDR pathogens in HAP and VAP. And Professor Monge has really emphasized some of these factors. One of them being prior IV antibiotic use within 90 days if your patient has septic shock at the time of VAP. If you're suspecting acute respiratory distress syndrome preceding to VAP. If the patient had been in hospital for 5 or more days prior to the occurrence of VAP, and probably if they have acute renal replacement therapy prior to VAP onset. So these are some of the risk factors that you will have to look out for. And when it comes to MDR Pseudomonas, again, prior IV antibiotic use within 90 days is one of the risk factors. Now, all these advantages of tazocine, but does it work? Yes. Tazocine works, and this is a study that was done looking at the efficacy of tazocine for patients who are being treated for nosocomial pneumonia. And it was a multi-center randomized double-blind trial, whereby on one arm, patients were put on tazocine, 4.5 grams, 6 hourly. The other arm, patients were put on imipenem, cilastatin, 500 milligrams, 6 hourly. And in terms of the clinical response, it is evident that tazocine had a response of 68% versus imipenem, cilastatin, 61%. So we'd say for the clinical response, it was comparable. Again, for the bacteriological eradication rate, which was being observed, for tazocine, 64%, comparable again to imipenem, cilastatin at 59%. So in terms of efficacy, we'd say they are comparable. But then again, when it comes to the safety aspect, tazocine has a better safety profile. So in this slide, we're looking at IDSA guidelines, 2016 to be precise, and they were basically looking at various patient classes and what they would recommend when you're having empiric antibiotic therapy for HAP, but non-VAP. So one of the recommendations is that you can use tazocine, 4.5 grams, IV 6 hourly, or you can use a third generation cephalosporin or a fluoroquinolone or a carbapenem. So for patients who are not at risk of mortality, but with factors increasing the likelihood of MRSA, then again, tazocine was recommended, 4.5 grams, 6 hourly, or you could use a third generation cephalosporin or a fluoroquinolone or a carbapenem or azithromycin plus vancomycin or linezolid. So in the last class of patients here, this is a high-risk patient of mortality or receipt of IV antibiotics within the 90 days. So again, piperacillin could be used, tazobactam, tazocine, 4.5 grams, 6 hourly, or third generation cephalosporin or a fluoroquinolone, alternatively a carbapenem, or alternatively there's aminoglycosides and azithromycin combined with vancomycin. So out of all these, it is important again to see that as much as, yes, tazocine has been recommended and other antibiotics, it is important to remember that at least tazocine is a lower inducer of beta-lactams as compared to third generation cephalosporins, and fluoroquinolones. So in terms of dosing and administration, for patients with normal renal function, so that is adults and children aged 12 years and above, we recommend 12 grams of piperacillin and 1.5 grams tazobactam in divided doses 8 hourly. So again, for your patients with a normal renal function or a creatinine clearance of above 40 millimeters per minute, we do recommend the same 12 grams piperacillin and 1.5 tazobactam in divided doses 8 hourly. So for your neutropenic children weighing above 50 kgs, the same dosing for adults is followed: 12 grams piperacillin, 1.5 grams tazobactam, 8 hourly in divided doses. For those children that are neutropenic but they weigh less than 50 kgs with normal renal function, then we recommend 80 milligrams of piperacillin and 10 milligrams tazobactam per kg of body weight every 6 hours, of course, and then you combine with an appropriate aminoglycoside. So when it comes to the renal impairments, for the dosage for the renal impaired patients, for patients with a creatinine clearance above 40, there is no dose adjustment, which is an added advantage when it comes to using tazocine. Patients with clearance of 20 to 40, a maximum dose of 4.5 grams of tazocine is recommended 8 hourly. For those with a clearance of less than 20, then 4.5 grams of tazocine is recommended BD. So the contraindications of tazocine would be for those who are hypersensitive to beta-lactams, including penicillins and cephalosporins. These are some of the adverse side effects that could come about. And I hope that the next time you get a patient who you have to treat for nosocomial pneumonias, I hope that you will consider using tazocine, and especially looking at the patients who are at risk of MDR pathogens. We're not coming up with any new antibiotics, so if we can use what we have judiciously, it will be of benefit to all of us. So thank you very much, and I welcome any questions or comments.
Thank you, Anne. Thank you, Anne Muriithi from PFIZER, for that presentation. I'm sure our members now are ready. You can raise your hand for those who are ready. For those who are not ready, you can also post your questions. Maybe we'll ask Professor Monge you can start by addressing one of the concerns from David Omega, which he asks do you still advocate physically touching patients in this era of corona? Maybe Professor Monge, you can respond to that as you await for more questions.
Thank you very much for that very good question. The emphasis of my presentation lays importance always, even pre-corona period, to listening to the patient, because obviously many times the patient will tell you the diagnosis even before you touch them. Many times when we do physical examination, we oftentimes may not have any additional information. So obviously, COVID will give you a clear history that may many times tell you that it's a likely diagnosis. If we are examining patients physically, and I run a COVID unit, one has to be very prepared and careful. We need to practice all the potential safety measures. But really, if we can make a diagnosis without physically examining a patient, using our clinical data, I think the way we practice medicine is changing a lot. And using lab data, using radiology, we can many a times avoid physical interaction in patients who are high risk. But obviously, the place of physical examination is still important.
Thank you very much. I am asking anyone with a comment or a question, you are free to proceed. When they silence, probably we'll ask a few of the physicians in-house, probably their experiences, and I'll start with Dr. Evangeline Njiru to tell us more about, because you also interact with the infectious diseases and how your experiences, please. Before I'll welcome Dr. James Muturi.
Thank you, Dr. Abuya. After my teacher has spoken, I do not have anything to add, other than to just echo what he has said, that COVID has changed a lot of what we are doing. Unfortunately, as it is right now, we are actually managing a lot of our COVID patients from the general ward, which is a risk for some of our other patients who have actually, some of who have contracted COVID from other patients around them. So with the numbers, we don't have the luxury of, being in a COVID isolation unit for all our patients. And we are learning to basically live with the disease, but try to be as cautious as possible, possibly dedicate a cubicle for our suspected and confirmed COVID patients. Thank you.
Thank you, Dr. Evangeline Njiru. Yes, as you say, that's true. Your teachers really educated us a lot. And I've seen even some direct questions to me directly, but there's this particular doctor from Marsabit called Dr. Duba, who is really thanking Prof for the wonderful presentation. And they was wondering if we could get that presentation on PowerPoint. I hope he wanted to address this directly to Professor Monge, or if we can get a record of this, a recorded version of this Zoom. Maybe we'll look at that, because Peter, our KMA secretary from Nairobi, probably has recorded all those Zoom and we can be able to get it. But all the same, I don't know what I will ask Professor Monge later on to comment about that request of PowerPoint presentation. And because he believes even other colleagues may be interested or to benefit from this, because they are hopefully wanting to reduce antibiotic resistance in their communities. And this says that, like from Marsabit, most of their patients in the OPD are admitted by clinicians who are equipped to prescribe IV medications without properly assessing the patient, and is wondering that this is probably slowly going to increase the resistance. And I know most of you know Marsabit is almost one of the border counties because Moyale is near Ethiopia. Anyway, maybe let me in the meantime ask Dr. Muturi James to say a comment before we request Professor Monge to maybe respond that Dr. Duba from Marsabit. Welcome, Dr. James. Seems not ready, but still keep on preparing to be ready. Are you ready now? Still probably not ready. So this issue of sharing this presentation, I don't know. I'll ask Professor Monge, what's your take on it? In the meantime,
the take on it is knowledge must be shared. Information is useful so long as it's passed from one person to the other. So Duba, we are on. You invite me to Marsabit, I'll still come.
Dr. Duba, may you say something? But there is a question which even I hope Professor Monge has seen in his screen, which was asking about the use of ivermectin in management of corona. But before Professor Monge Monge answers that, maybe Dr. Duba, are you able to be online and make a comment? Dr. Duba from Marsabit, please. Okay, maybe Professor Monge, this question from David about asking about ivermectin in the management of corona.
This is, the treatment of corona has come with the use of many molecules, from chloroquine, hydroxychloroquine, lopinavir, ivermectin, and we know that these molecules are being repurposed because we didn't have treatment. With the current evidence, the things that show clear benefit in treatment of corona is 1, steroids in people who need oxygen, 2, remdesivir in people who present early, and maybe other anti-inflammatory agents such as tocilizumab and baricitinib. But obviously, where data is strong is in use of steroids. There are bits of information that may not have met the threshold to allow using some of these molecules in protocols. But I know people have tried to use things including zinc, vitamin B, vitamin C, but many of those molecules are a doctor do something kind of molecule. So the evidence is yes, in for corticosteroids, reducing the duration of hospital stay by remdesivir, and probably some benefit with some of the anti-inflammatory drugs such as tocilizumab and baricitinib. I personally do not use ivermectin. I know physicians who use it. That's my take on it.
Thank you, Professor Monge. I think we have had that connection. Dr. Duba Doyo from Marsabit says he has a very unstable connection. And I've answered that, yes, you have accepted. They will see a way of sharing your the knowledge to him. In the meantime, I hope you have also seen from Edwin Wanjohi asking about if there's a role of these, either the oral or IV steroids in the management of acute bacterial community-acquired pneumonia. So he's wondering if these steroids, whether IV or oral, have any role.
Steroids are not used in treatment of pneumonias. Steroids are more useful if you are dealing with severe tuberculosis infections, particularly where there are some serositis, but for acute bacterial pneumonia, no. The use of steroids in severe sepsis is also quite debatable.
Thank you, Prof, for that. I'm seeing in absence of any questions, I'll ask any of the members for the few minutes we have before we officially close. Anyone with a burning issue or a comment or an addition or a subtraction, please, you're welcome. Anyone with a comment? Dr. Mogusu, I almost saw as if your microphone was getting on. Dr. Mogusu, how are you?
Fine, thank you, but I have no comment. Thank you, the presentation was great.
Okay, thank you. Then I think with that, if there's no more comments or there's no more additions, I would wish to bring this to an end, a close. And before we close, I sincerely wish to thank our main speaker today, our main presenter, Professor Omonge, for the good presentation that we have learned a lot, and especially being as a specialist of infectious diseases and all those that we have learned today about the proper management of lower respiratory tract infections. And I'm sure that a number of people have been here because you have been doing your clinical trials in a number of various institutions, have benefited in one way or another from all those clinical trials, the adoption and that has gone on, and the review that you have also been undertaking. So I wish to sincerely thank you. And next time we will call you, I think today, somebody underestimated the capacity of our people who are going to join. Within less than 5 minutes, we were more than 100, and there were even other more 100 and something waiting to join, but they could not be able to join because probably they got for a smaller Zoom instead of a webinar. But still the same, I wish to thank you. I also wish to thank PFIZER Pharmaceuticals and especially Anne Murray also for the presentation that you have given us, so that it keeps on enriching us about what we have learned today. I also wish to thank Kenya Medical Association ELDORET Division. The chair was held up, Dr. Jakait. The secretary spoke, that is Dr. Edith Koba, and all the other officials. And also thank Anton Boyd for facilitating and ensuring that we have this webinar tonight. I also wish to thank each and every one of you who found time to be able to participate, to be able to attend, to be able to listen, and to be able to learn at least something which we can be able to be useful to use in our day-to-day practices in treatment and management of patients. At least you heard Professor Monge say, these are human beings we deal with. We touch human beings. We are not treating just a disease. So thank you very much. And all those that have not been able to thank you everyone, and have a good night. Thank you.
Thank you.
Thank you, Prof.
Thank you, everyone.
Thank you.
Thank you, and thank you for the invite.
Thank you. We'll invite you again.
Most welcome.
Thank you.
Unazima nini?